Welcome to the webcast, Robotic Utilization in CLI in 2018. Protect your staff, protect yourself. This webcast is taken from live proceedings at the 2018 Amputation Prevention Symposium and is supported by an educational grant from Corindus Vascular Robotics. The moderator for this program is Jihad Mustafa from Advanced Cardiac and Vascular Amputation Prevention Centers in Grand Rapids, Michigan. The panelists for this program are Paul Michael from Cardiology Partners and JFK Medical Center in Palm Springs, Florida, Eric Scott from the Iowa Clinic and Iowa Methodist Medical Center in Des Moines, Iowa, Brett Weichman from Vascular and Interventional Physicians in Gainesville, Florida, and Timothy Yates from Mount Sinai Medical Center in Miami Beach, Florida. Here are their disclosures. Upon completion of this activity, participants should be able to explain the occupational risks associated with radiation exposure, discuss best practices and treatment options to improve patient outcomes while reducing radiation exposure for clinicians, and recognize the benefits of robotic-assisted peripheral interventions for complex CLI cases.
And now let's move into the future. Who would have thought that robotic utilization in 2018 will move on to be used into the CLI therapy? And the title here is to protect your staff and protect yourselves. Have some really nice transition from the current status quo into the future. The CoreBath GRX system is the only FDA-cleared robotic system for coronary and recently peripheral intervention. And what you're seeing here is real, and this is the experience from the coronaries, and you can put it this way, you can put it sideways, there's multiple ways where you can do it. So to optimize your comfort level and how you want to do this. And over time you find that you actually, not every vascular specialist like the same position that you see here. But you have this precision that is going to be uniform of guide catheter, wire, and rapid exchange catheters. Now, in terms of the guide catheter for peripheral, we are perfecting that. But in terms of the wire, this is one thing I'm going to show you today that you're going to be extremely impressed with. And it's very hard sometimes to impress us, all of you guys, because you've had great experience with wires, because you have to, based on the complexity of the disease that you deal with. So you've had developed this phenomenal wire control, but I thought I would not find something that would control the wire more than I do, but this is phenomenal. So I'll share that with you. The radiation reduction is amazing, and the resolution monitor is also amazing. The robotic precision sub-millimeter measurements to determine lesion length and appropriate stenting, discrete 1 millimeter position of devices, and if you wonder like where would that be important for you, you'll see in a second. It's actually very important. Device fixed in system during procedures, fixed in a wire in the same place as you advance things in and out, and the procedure automation of wiring with rotate and retract is ROR. That system is amazing, and hopefully I get to share it with you. Smart procedure automation. So the first automated movement in technique series for GRX. So there's some publications on that from the coronary side, where they found there's a significant reduction in wiring time with reduced variability. And the reason actually you see that because there's this controlled motion of the tip of the wire that I thought, we can do it ourselves, but to do it like the robotic arm does, at this point I would say I can't, but maybe in the future I will, because we all like a challenge. So I'm already challenging the robots, and we'll see who wins. I'll let you know next year. So rotate on retract, and this is a nice software. Again, it's a new thing for us for CLI work, but it's a nice addition. How many times do you move the wire forward and backward while rotating to advance the wire through bifurcation or calcified lesions? The reason I went backward here, because I'm going to focus more on this portion in the CLI world or the peripheral world. You find actually with a robotic arm, this is much easier than you think. I'm sure you probably thought it would be harder in the peripheral, but actually I find it to be easier, and I will share that. I will show you in a second. This is here for occupational hazards, and you can deny it all you want, but back pain and fatigue is real. But the more serious issues is radiation exposure and the damage that it can cause. Unfortunately, there's some real deal. I mean, we lost a real dear colleague recently for brain tumor. So 85% of brain tumors in interventionalists are from the left side, and we know that for a fact now. Cataract is a big issue, and the carotid atherosclerosis as well is another issue. And I don't know what else we're going to find as the time goes by. Orthopedic strain and fatigue, this is a major, actually almost a career stopper for some people, and it's a major problem for a majority physician, and the average age is actually 54. So hopefully none of you is going through it, but it is a problem because 60% incidence of spine issues after 21 years in practice. So it's kind of like you're in that range. 42% incidence of spine problems, and general population average is 2.3. So you can see that it's a major issue. And the days of work missed is 33%, and imagine the cost and loss of income with that. So radiation reduction, 95.2% radiation reduction to the physician when using the CorePath technology. And as you know, the oblique views, especially the RAO oblique, pretty much is giving you the radiation, especially the scattered radiation, straight into your lower extremities and then up to your body. And when we use a shield, actually most of us put it next to the eye on top, where actually the shield should be in the bottom, really, to protect you. So anyway, the radiation shield workstation eliminates scattered radiation, and if you know the 1/4 inverse distance, so if you add that to the shield, you're pretty much not getting any radiation. The RAPID trial is a robotic assisted peripheral intervention for peripheral artery disease. It was done in Austria with Dr. Brodman, and I wish she was still here. She would have helped us with the discussion, and the study chair was Dr. Mahmoud. The trial design was a prospective single-arm, single-center, non-randomized study for the CorePath 200 system. The idea was to examine the performance during interventions of the SFA and patient outcomes through 24-hour post-procedure. So just looking at the acute outcome, but also just the time it takes and the acute events during SFA therapy. The primary outcome measures were successful cannulation of the target vessels using the 200 system, CorePath system, and there was no no device-related serious adverse event during the procedure. The inclusion criteria were patient population, symptomatic disease, presence of CLI, and or life-limiting claudication, and a disease involving the SFA. The angiographic inclusion criteria, the SFA disease with more than 50% disease, and also occlusion of up to 50 millimeter. The 20 patients that were enrolled to Rutherford 2 to 5, the Rutherford class 2, R2, 30%, and then 3 is 60%, CLI 4 is 5%, and CLI 5 is 5%. So it was more focused toward the larger vessels at that point. 29 lesions by which all treated by CorePath system, 26 over 29 lesions in SFA, 4 popliteal, and 1 had both SFA and popliteal. The balloon angioplasty was done robotically 65% of the time, and also balloon angioplasty performed robotically with provisional stenting was 34%. All stents were placed manually, and as you know, the system accommodates rapid exchange. So as we have more rapid exchange tools, we'll be able to use it more. But also, as the device, the robotic itself evolves, we'll probably be able to use it more. So both ends are working toward accommodating the technology. The rapid results, primary endpoints were met 100% in terms of success. The device success, which is basically by cannulating the target lesion, and the safety, which is absence of adverse events. The second endpoint was the clinical procedure success, less than 50% residual stenosis of all CorePath treated lesion, and a conversion to manual provisional stenting, confirmed by independent core labs. The variables here at core lab technical success were 100%. It's actually nice to hear that because, every time we have a new technology and you put it in our hands, especially for peripheral, it takes you out of your element. So it's very nice, and congratulate Dr. Brodman for being able to do this study. So patients with device-related SAEs were 0%. The current comparabilities with the CorePath GRX, guide catheters advanced and retracted. We can rotate them, and 5 to 7 French system compatibles. Guide wires 014 system, and actually we can squeeze the 018. We like to always challenge things, so they didn't like it, but they're okay now. The RX device advanced, able to advance and rotate devices, but not rotate them. The proximal shafts compatibility is less than 2.3 French. So the future of vascular robotic, advanced device manipulation, and this is where you and I really come into play here. As you see this device today, please start to think, what would you like to see? And share that with me at one point, because we would like to see and expand compatibility of the current device and the future iterations that they might make. And robotic system procedure, it worked really well for the coronaries because it has short segments, predicted segments, but for the SFA and popliteal and tibials and the pedal loop, we have to be involved in terms of feedback. So anyone that is involved with the device in the future, we probably should all get together because it's a small group of guys at this point, and girls. So the sooner we work together, the quicker we can get this actually perfected. It's really helpful to have it. This is a recorded case at the Advanced Cardiac and Vascular Amputation Prevention Center, where I just want to show you the reality of how you proceed with such procedure. So initially, you have to put the axis yourself, obviously here, and we use ultrasound. It's the bifurcation, and we use ultrasound to place a sheath. And as you can see here, there's a nice bifurcation, and we select an exit strategy. So maybe I would get some help here from Brett. What do you think, Brett, here in terms of looking at this bifurcation? Where would you place your sheath if you were doing this case, antegrade?
Well, we always try and take a quick look at fluoroscopically to see if we can see where the femoral head is. With ultrasound guidance, obviously the key here is trying to avoid wire placement in the deep femoral, but there are some tricks that you can use to advance that wire into the SFA.
I like what you said, actually. You look to see where the femoral head is. That's a very good point. Dr. Scott, there's some data published on the safety element of the ultrasound versus angiographic guided access. What's your thought on current data out there?
I I use ultrasound for every femoral access. It shows you the proximal landmark at which you can get in trouble if you're into the external iliac artery risking retroperitoneal bleed, but it also, in this example, shows you the femoral bifurcation nicely. So when you're going antegrade, it allows you to move as proximal as you can, but yet safely, because it's in that zone of visibility. And then I use a micropuncture kit. I'll put a little shape on the 018 wire, and then under ultrasound, if someone lays out, or you, lay out the bifurcation nicely with one hand in the probe, with the other, you spin the wire, and you can watch it go into the SFA. Single-handedly, you can direct it in many instances.
I could only actually do it single-handedly, but since we have an ultrasound tech, I kind of take advantage of that. But you can do it single-handedly, like you said, and the curve is good. Do you do a single curve or double curve?
Single curve.
Okay, and
maybe if I was more sophisticated, it'd be two.
No, a single curve
I
is great.
think one is usually sufficient.
You know, do you mind telling us how far, like, what's the length of the tip of the curve that you do?
That curve is probably contained within the distal centimeter of the wire. So, I mean, you don't have much room to work.
That's good. I mean, this is a very good point, right? Because that single curve that you make, right, allows you to just make that little loop up into the SFA and just push it down. Dr. Yates, you have the same experience as well?
Very similar. We do the same thing with ultrasound guidance, and we use the kit wire with a micropuncture kit. It comes with a braided tip, and we'll give it a gentle curve at the distal centimeter or two, allow it to float in. We're also looking with access here. We're looking for the calcification of the wall, trying to avoid those for a clean placement, particularly if we're planning on closing at the end of the case.
And last question, Dr. Michaels, and there's something here in this picture that I would like you to hopefully pick on and tell us, because this case that we chose to show you today, if you notice there's something unusual about it on purpose, because we don't like to do anything straightforward. So what do you notice here?
I think seeing this image is the reason why the country is mandating rear view cameras in cars. Seeing that plaque there to help you plan your exit strategy and avoid it is the equivalent of seeing a football or a child behind your car backing out of a garage. So to use ultrasound is such a safety tool. It's a power tool. It's more than just a safety aspect, but it helps you plan not only your entry, your exit, it skyrockets your safety, and it gives you a lot of comfort to go antegrade and use a lot bigger devices.
So actually,
Is this a closure device? Is this an angioceal?
we haven't, this is just going in. We haven't actually started the procedure yet. But this is the posterior wall plaque, which is a very common finding at that location. And you know, Scott, you cut these arteries all the time. Is that what you normally see somehow, distal common femoral artery, Dr. Scott? Eric,
Right, so common femoral plaque is typically in the posterior wall. But one of the biggest advantages of ultrasound is actually when it's in the anterior wall. And if you're sticking under anatomic landmark or fluoroscopic landmark, sometimes you completely miss it. But on ultrasound, sometimes what you see in the anterior wall completely changes where you're going to access the vessel. Then it becomes a huge asset on the way in as well as on the way out,
You're right.
depending on the closure device you use.
Absolutely. Angle, location, etc.
You don't see it as often, but that can be a real problem.
Brett,
The one thing I would caution to the ultrasound-only folks is the high bifurcation.
Yes.
And so I realize that fluoroscopy is not necessarily going to be 100% accurate in terms of the position of the inguinal ligament, but I can tell you, having stuck with ultrasound without having peeked at the femoral head, that you can stick the external iliac artery and find yourself in a world of hurt once you get the sheath in. Right. So again, we only take a quick spot of the of the femoral head under fluoro, and then stick to ultrasound guidance.
Let me see
the high
if I
bifurcation
can,
is a real thing.
Actually get a different answer for you, okay? Anyone in the audience here, I see a CLI fighter right there. Okay, stand up, please. And come take a mic and fix the situation for us. Come grab a mic. There's a way, guys, and he's going to tell us right now, how can we use the ultrasound alone and not use any fluoroscopy? Any suggestions to how to do it?
Yeah, well, I mean, kind of like what you guys were talking about, doing it single-handedly. You can do it and watch the wire go into the SFA You can stick the high SFA directly too.
That's for high bifurcation, right? That's a good point.
Exactly.
And how about the femoral head? How can you, is there a way that you can actually locate it without having to use a fluoroscopy?
Yeah, I was just talking to Mike Watts about that. You can see the femoral head on ultrasound, it just shadows out. I mean, it's bone. So you can actually see exactly where the femoral head is.
Where is Mike? Is he here also?
He's right there.
Of course, it's going to be
You guys
easier.
should come up to the front, like maybe right here. That would be nice. Okay.
No, but you can, it usually when near the common femoral artery, it just looks like this black
That's a good
structure.
point. So actually, what we normally would do is increase the depth, and you can see exactly what you said, long axis. You can see the common femoral head, and you can see the external iliac diving.
Exactly.
So we locate that and then go away from it, actually significantly. So you can measure exactly how far you want to go away from it and how close to the SFA, the os of the SFA. And in here, I was trying to trick Dr. Michael here, but he didn't fall for the bait. The obesity of the patient on the groin. Do you notice the significant pannus here, right?
Yeah.
All right. So the reason we picked this patient on purpose for the robotic case is to actually start with the complexity of the patient access, body habits, and to see if the robotic can still handle something like this, because this is the real world, not the BMI of 20 patients. Thanks for actually answering that question. And so do you use depth, right? You increase your depth.
I don't fluoro and check the femoral head, which, I mean, I've run into trouble once or twice where I wasn't happy with where the stick was, but in general, 99% of the time it's fine.
Okay. Well, we'll grab Dr. Watts and come back and stand in the front. All right. Well, guys, here's what we normally do, and this is sped a couple of times, and the patients with large pannus, we found kind of a unique method to actually get integrated access. And the problem and the challenge is we need to and have to sometimes because of the CLI nature of the disease, right? You have to do peer loop reconstruction sometimes. You have to do distal tibial intervention sometimes. So what we do is we pull the pannus back, and we found that the ultrasound, and somehow in obese patients, for some reason, I'm not sure why, the common femoral artery somewhat a little bit lower than expected. I'm not sure why at this point. So so far we've been doing this technique, and then we do exactly what my friend here mentioned, is that we actually stick the proximal SFA in probably 20 to 30% of the patients, if the SFA is 6 millimeter or in that range. So here, you know, we always get access, and now we know that we have an entry strategy, an exit strategy, and this sort of angiogram that we did is just to show you today. Normally, we just move on from the ultrasound, but it's good to show you. Here's a disease that I picked for us today. I didn't want to pick something too complex, just this. And let's see if we can cross it. So, and I'll start with Dr. Watts. There you go, Mike. Thanks, man. So, you know, in terms of wire, and forget about the robotic arm, but wire, which wire would you choose, and how would you cross this lesion?
Yeah, so it looks to me like there's probably, you know, I'm trying to see if there's like 1% of a lumen there and at that hiatus.
Okay.
There probably is. You know, so something 0-4 hydrophilic that's flexible, you might be able to get a command through there is probably what I would do, and just try to just navigate through there. And once you get through there and follow it up with whatever your support catheter is, you can probably work your way through. I'm trying to decide, my eyesight's terrible.
You're too young for that. What do you think about the tibials?
You think I am. I'm not. I just look like it. You know, once you get lower down, I would do another run. Once you get to the P3 segment, and then you know. We'll see what goes on from there. Is that what you're thinking? Okay. Yeah, and I'd probably oblique off a little bit to see if I can get a better view of that AT and really get a good trifurcation view from there.
What about my panel? Bruce, I'll start with you. What do you think about the tibial runoff? Dr. Watts, thanks, man.
Absolutely.
So I got the names of the wires, and we'll see if that works or not.
Yeah, I agree. I think that there's a little bit of misregistration artifact there from patient motion, so it's really hard to tell what you have below the knee. So I would get a catheter down, and this kind of makes the point for the benefit of super selective angiography once you get into that segment, because really your outcome for that distal SFA popliteal lesion is going to largely depend on what you can create in terms of outflow.
Absolutely. Tim, wire catheter? Which one?
I would approach this with an 014 wire. Typically would start with a command wire and then a support catheter. I would usually use an 018 CXI just to give myself a little more support as I cross through that lesion.
So CXI 035 or 018?
018 is typically what I follow with the 014 wire, and I wholeheartedly agree that super selective angiography and completely filling the vascular bed is crucial here to know what's hibernating, what's truly occluded, and what's patent.
All right, so we got enough data on which wire, which catheter so far, and then we agree that maybe there's total occlusion of the tibials. We don't know yet. So I like the fact that we didn't have to wait. So Eric, let me take you into the next view here. So here's more of a little bit more contrast, and then you see a single vessel runoff. So you definitely don't want to lose any collaterals, right? Because at this point, you worry about it. So now we're going to treat. So what kind of sheath would you put in here based on the PANIS, the complexity of the disease, which is obviously very complex here. It's an extreme complexity, single vessel runoff, and there's occlusion of the AT and the PT. So which sheath would you use to support you with a robotic arm?
So I'd probably choose a 6 French sheath and probably a 45 centimeter sheath, a longer one, because I think you have length proximally.
Excellent.
To get that sheath closer to this lesion. I try to put sheaths as close to the lesion as I can. So if the majority of your SFA is patent and doesn't need to be treated, then you can put a sheath in it, and you'll be closer to where you work. You have better pushability, better visibility.
So 45 centimeter, okay.
6 French, 45 centimeter.
45, okay.
And then, so I like the idea of the 018 catheter as a selective catheter to inject through.
Okay.
You get a lot more dye down versus an 014 catheter. And then you'll see something like this, that yes, in fact, the perineal was patent and looks pretty good. Next question is, what does the foot look like?
Right. That's a good point. So Paul, based on the flow by itself right now, I'm not going to give you anything more. What do you predict is going on in the foot?
Looks collateralized to me because there's good outflow of the perineal. It has to be going somewhere.
It'd have to be perforated.
The speed, right? The speed of the flow.
It has to be going somewhere, but it may not be going to the right place or the place you want. If this was a wound, for instance, that may flow in the complete opposite direction, and that may give you the full explanation as to why you have a non-healing ulcer.
It's always the calcaneal branch. Whenever you see that nice flow in the perineal, you think about the calcaneal branch, and here it is, almost always the same case, or the anterior and the posterior communicating arteries that are patent. So, but here I actually, the picture I showed you at the level where the anterior and posterior could be, but hid the calcaneal branch. So it's a good point, guys. Thanks for. Well, we need a braided sheath, right? I mean, absolutely correct. Long sheath and a braided sheath. So with a large PANIS, integrated access, you want a braided sheath because of the many complications that can happen if you have a soft sheath. And now, if there's no large body, have a different situation. Here's I want to show you the preparation. So of course, you might think this might take forever to put together, but actually the cassette that comes in with the device, the device is already mounted onto the table, and what we do is we open a sterile cassette, which is right here, and we place it, and everything is now completely sterile and ready to go. This is our team. They're going to be the one supporting what I need on the table, and now I'm going to go and sit down and start working. So this is I hate to show this, but just to show you guys that I don't have lead on, because one of my CLI fighters one time called me out saying that I was doing a case and I had my lead on sitting down. I'm not sure who it was. Maybe I can guess. I'm not sure. But that was good. That was a good call. Thanks for calling me out. And
Got to keep you honest.
Oh,
talking
was
to
that
stuff.
the? Okay, that was a good point. Why do you have your light on if you're doing robotic case? Because you know what, we all have ADD and you can't deny it, and you just get up and do something and come back. So anyway, in the beginning, I used to keep my light on. Now I don't. So I just have to. So look at this, guys. This is phenomenal. So now you have complete control here, and then you have a screen which is in front of you that gives you phenomenal visibility. And hopefully we can zoom in on ROR, which is my favorite element. So I did exactly what everyone mentioned thus far. So actually we're all on the same page. But this is my favorite component of the device. So here the action begins with precise rotation of the wire exactly into the target position. So this is what I typed actually, it's my own notes. And look at the precision. Here you go. I want to show you here what happens. Look at that. You see how I turn the wire? And so you're going to predict where you want to go. Here you go, once again. The sort of a half turn. I'm sure you guys can do this with your hands. I'm not saying you can't do it with your hands. You can all do this at this point. But the fact that you can sit here and do that, and you know that if you keep going, you might lift up the plaque, so you turn away from it, and you probably would do that in real life on your own. But the robotic control is amazing. So the half millimeter turn, etc., and you're moving it forward at the same time. And I'm actually talking and whatever, so it's not really that difficult to do. So let's keep going to see what happens when you get to the area where you thought maybe there's a 1% PNC. So what do you think here, Tim? I think, Tim, you said there's a 1% opening, right? Or is it Brett? I'm not sure. Someone said there's maybe 1%.
Doesn't matter. What was the question, Dr. Mustafa?
Someone thought maybe there's some opening left, not CTO. It was a very short CTO. Oh, Michael, you did.
Dr. Watts.
A very short CTO, actually. I can't take credit for it. I think maybe it was open. I'm not sure. But there's a little bit of buckling, so kind of took it into it and went through. Let's say it wasn't complete. It was 99%. How was that? All right. So the further crossing with successful arrival to the target lumen, did that. And notice, I just want you to see here what's going on. Let it play one more time, and then we'll move on to the next slide. Take a look here. The wire goes into collaterals, and the good thing about the ROR here, once it goes down into one path, if you actually don't like that path, you bring it back and you put on the ROR and rotate it, and you bring it down. You won't be in the same path again. So this is the beautiful thing about it. And because the precision of that is phenomenal. It's hard to impress you guys because I know how good you are at what you do. But I was actually impressed here because I didn't go back into that collateral one more time. So just a slight rotation, and I was able to go through. So this is probably baby steps at this point, but the phenomenal aspect of it so far is the precision of the tool. So we crossed. I thought maybe there's some resistance here and there, but the wire, when it buckles, just move it back and forth and rotate it until we crossed. And here, again, there's a lot of collaterals, and and look how fast you can go if you want to, and how slow you can go if you want to. And notice here, when I pull back and I rotate, you don't go back in the same area. And this one here, twice I made the same mistake, but the third time I went through, and that I think lowers the perforation rate, the section rate, etc. So we advanced this wire about 400 millimeter without any consequences. That's very impressive to do from sitting here. This is an angiogram done. I think in the future you can do it from where you're sitting, but right now somebody has to inject. But actually I'm controlling the floor here. So this is a selective angiography, like someone mentioned, and it's great because now you can see tremendous more information about the tibial pedal segments. Look at the nice, precise advancement of catheters. Phenomenal. Kind of what you like to do. So this is IVUS in now, and the IVUS is rapid exchange. So anything that is rapid exchange, you can precisely move it. And here we got it. I'm moving it, and now I'm going to go into just slight movements, like 1 millimeter at a time or even less. And this reminds me of a tweet that went on a few days ago. Just look at this, kind of keep pushing on the plus, or you can just put your hand on it, one of the two things. And now you can actually move the IVUS as slow as you want or as fast as you want. And if you want to take your hand off, you can just stop it there and take a look. Anyway, that's really nice feature of it. And then you can mark it as you go where you want to stop. So just to show the 99% versus 100%, anyway, you guys can decide. It's not a big deal. All right. So we crossed, and now we're going to do laser, because laser is available in rapid exchange. So notice here, my friends and supporters in the cath lab are placing the laser, and what they're going to do is they're going to advance it to the point to where the robotic arm grabs it, and then they just leave it alone, and I take over. So they connect the saline portion and connect it to the laser machine, and then after that, then we'll connect it to the arm, and then I'll take over from there. So it's kind of nice to be able to do that. So here we did a combined ultrasound and fluoroscopy. We don't always do that. This is just to show you guys, because it's not fair to expose the ultrasound techs for radiation. Here to show that you can actually go really slow with laser. And what really kind of hit me here is I think this robotic arm is phenomenal for laser, because if you use the plus system that I'm using right now, you can go extremely slow. And the bubble, if you notice, was in the front of the catheter the entire time. And if you do it by hand, I think the more fatigued we are, the faster we go. So anyway, the rest of it was very nice. And this is continuing the laser all the way through. This is, so looking at this one right here, Dr. Yates, where do you think, that was Dr. Watts right? Was it a CTO or was it a 99?
Well, I've never known Dr. Watts to be wrong.
So, all right. Notice how the bubble kind of works on the sort of the lesion, and Dr. Walker did a great job showing how the laser works. And if you actually watch here, it really happens exactly as he explained it. So we let the laser do the work, so go slow to finish fast, and we did. And we lasered all the way down where the lesion was found to be consistent with the IVUS. So we went into the TPT and slightly into the perineal. And then look at this. This is the best part. Taking it out is so phenomenal. I mean, I can't tell you how much I like that part of the procedure, because now I don't have to worry about the wire. We're like kids, when you get toys like this. And this is where you fall in love with the device. When you get to this point, taking it in, taking stuff out. And next slide is the first thing that hopefully went through all your minds. What's happened to the wire, right? But look at this. Here's a balloon, long balloon. Look how fast I'm moving it in. Isn't this awesome?
You can no longer blame it on Fadi or a fellow or a resident if they lose wire access, though.
I know, that's kind of bad.
Consider that.
So Jihad, tell us, how many devices can this thing control at the same time? Is it the wire and one device? Is it three things?
Right now,
how many fingers does it have?
Right now, it's just got a sort of side port, so you can have the wire and a single device at this point.
So it'll fix your wire,
yes,
and control a device over it.
Yes. Well, and Eric, it's a good question, right? Because for us, when we're doing CLI, that is absolutely something that in the future is going to be one of the features for this to continue to support CLI. Double wiring, kiss a balloon, etc. So you're right.
Well, and also, you think about some of the topics that were brought up at the lunch symposium today about atherectomy needing to go slow, meticulous. You almost wonder, things that are really slow, this thing could do better than you and I. It has more patience.
Absolutely.
But it also would have the ability to even to measure pressure at the lesion so that you don't exert too much force. It could control things in a way that you and I wouldn't.
You're absolutely right, Eric, and especially this plus system, which I really fell in love with here. You can go really slow, and if there's any resistance, and the buckling actually happens in the slow motion, because buckling is a problem almost always. So it happens in a slow motion, so you really get to see it and stop right there. So I haven't actually seen much of that because of the what you just said. The ability to go very slow, especially with atherectomy devices. So hopefully we'll see more atherectomy devices with rapid exchange abilities. And then balloons. If you want to advance a balloon fast, you can. Slow, you also can. So both abilities are available, and I really like that component of the device is how slow I can go and how fast I can go, and the different exchanges. Actually, you'd think it would actually delay you. In fact, it doesn't when it gets to this point. The learning curve is not too steep, so hopefully in the future we can all be able to use this because of the radiation exposure with CLI therapy. So this is atherectomy followed with balloon angioplasty, and the inflation times is 2 minutes in each balloon. And now we're advancing a thrombectomy catheter, and notice this is being done manually. All right, so with the thrombectomy, everything looks good, because single device, the last thing you want is anything to go distally, and selective angiography afterwards. So what do you guys think so far? I will start this time with Paul.
I think it's time to go back to our IVUS findings, and let's do some sizing.
Okay.
And let's plan our exit for PTA.
NG for PK. All right. So here's an NG for PK. And we haven't seen the tip of the wire. Where am I going? Okay. And here's the runoff to the foot. So that's what you said, right? And notice the tip of the wire is exactly where I placed it in the beginning. And this is extremely important, guys, because now we can have that confidence that wherever you place the wire, it's going to stay. And we have significant improvements of flow into the foot. Now you can make a decision to do additional balloon angioplasty, or you can stop. And clearly here we did sequential angioplasty, so we started with low profile balloon and then went up to a higher profile balloon to get the results that we like to get. So here's a secondary balloon, and notice how nice and smooth you can move it through. And if there's any buckling or problems, probably you can stop immediately, and once you take your hand, immediately it stops. Here's the balloon being inflated. So as we inflate balloons, Eric, what do you think so far? Is that something that is attractive to you at this point, based on what you've seen to this point?
It looks like there's some areas where you could potentially get some additional lumen gain.
Lumen gain. What about the device itself, using it yourself? Is that something you would think like you would use in the future?
The robotic component of this?
Yeah. Robotic.
Yeah, and I think it has numerous advantages to it, but I think from a broader perspective, the things that we do for CLI now are more sophisticated, perhaps more time-consuming than we did 5 or 10 years ago.
Yes.
Our radiation exposures in each of these cases is only increasing.
Yes.
And the number of people doing it isn't particularly large either. So those who do it frequently, and the doses are higher and higher. We need an answer to that.
Absolutely, man.
And to sit in the corner and get 1/10 of the radiation, that has serious appeal.
You're right. One of our faculty actually gave a lecture, and during his lecture, I don't want to repeat his name, but he gave a lecture. But during his lecture, he said that he got a couple times a year a letter where he had to stay away from radiation. So you're right. I mean, we are getting exposed significantly. Tim, what about you? I mean, when do you think you'd like to implement this technology into your practice?
Well, I think the technology is very impressive, and I think the options are broad. I think automation and even applying AI might be able to facilitate or move some of the parts of our typical procedures through more quickly. A question for you, since you've had your hands on it. Many of the CLI operators here in the room rely heavily on feel and response, catheters and wires, and you're not getting that same sensation. You're having to retrain your eye to respond and the movements of the wire. How long did it take you to feel comfortable with that?
That's really an excellent question. So you're going to replace that with a visual tactile feedback. If you notice when we advanced the wire, look how slow I went, but it was an effective movement, right? Every time I moved, it was an effective movement across something, and I moved forward. So the tactile feedback is replaced now by visual feedback. So you don't feel anything, but you can see quickly what's going on and stop. And, you know, I'm not sure if we can ever say we're going to get tactile feedback. So it's going to be visual. And it's actually, having done few, it's really not bad. The visual tactile feedback is not bad. What do you think about that? I mean, is that something important to you?
Can I respond to that for a second, Jen?
The feedback, is that something?
Tactile feedback?
Tim, I was thinking the same thing, like while we were on this presentation. I was thinking, actually, any of us who have trained residents and fellows, it's actually kind of the same thing, because you have to train your eye to, they don't know where the wire is going, right? And you see that wire path with no fluoro going where you think the SFA should be, and it takes some 15-degree turn, and they don't know any better. And you got to be like, oh, you know, stop it. So that's kind of how I kind of thought about it in my head. We're already trained a little bit to watch other operators, and
Yes.
and there's, you already have some of that visual.
The visual feedback, okay.
Just from anyone who's taught anybody else to actually do these procedures.
That's an excellent point, really. Thank you. Yeah, I mean, so basically, if you know the anatomy and you expect the wire to go, so based on that, you can actually stop and redirect. So it's really a great tool for those of us that have a large number of CLI procedures. I mean, Fadi and I do a significant number of procedures a month, and they're very complex. And remember, you know, based on the basic science and the physics of radiation, the larger the body, the more the scattered radiation, right, that you get exposed to. So based on that, I chose this patient because this patient is obese, has large panas. The radiation exposure from a patient like this is twice as much for a patient who's got a lower BMI, right? Mm-hmm. And then the fatigue factor, you know, I'm not sure if Dr. Saab wants me to share that with you guys, but he's already like complaining about his back, and every day is like, oh, my back hurts, I can't work and stuff. So this is we got it for Fadi, actually, more than anything else. So Dr. Saab is going to be the one using this. I feel sorry for him. So
he's shaking his head over there, actually.
Oh, is he? Where is he? Oh. You're welcome. I bought the device for you. Do you think this is something that you can see in the future for the majority of us or selective people of us? What's your thought?
Well, it goes to the new technology question of what are the barriers to widespread adoption, of course.
Yes.
And that's, I think that I'm kind of extremely impressed by the engineering behind this to generate algorithms that torque the wire to almost replace the tactile sensation that we all kind of cut our teeth with. So, you know, you have to commend the folks at the company that have kind of take that engineering and then made it fit for something like this, realizing that it's only right now for coronary peripheral intervention. I think there's tremendous upside potential for more complex cases like embolizations, neuro work, and so that's You mentioned the point about wire position. And,
Yes.
when we're dealing with extremely tortuous anatomy in the abdomen or intracranially, and wire position is critical, the fact that it's pretty secure is pretty impressive. So I think there's a ton of upside potential, and so I can't wait for the next layer of engineering.
Thank you for raising these points. Actually, these are all very important points because intracranially, any motion or movements with the wire is a problem. And so we're talking about CLI, but intracranially as well is important. So in the future, probably we'll see a live case from you on that. Okay. So Tim, I know you're tech savvy, and CLI fighters are tech savvy. And so for you guys, how attractive is this right now?
I think,
Paul, you as well. I mean, everyone.
The good-looking guys answer first, please.
Sorry?
I said the better-looking guy can answer first. Go ahead, Tim.
The better-looking guy. Oh, I'm sorry. That's
so I was
definitely that's not Dr. Saab. So you can go ahead, Tim.
I think this type of technology, certainly in surgery, the robotic experience is pretty broad at this point. I think that you can kind of apply the same thought process when we went from exploratory laparotomy to laparoscopic surgery, and the level of detail and the precision. I think that's very attractive. I was speaking with Kristen from Corindus today about this. The machine can be trained to use different wiring techniques, if I'm not wrong. It can even train your own specific type of drilling or torquing process, right? So I think that's phenomenal.
So, it's only going to get better, actually, and I'm very excited about the potential of this, and I'm hoping that you guys are as excited, and everyone else in the audience is as excited, to have such tool and have zero radiation at the end of a procedure like this. It's not a bad thing. Our technologists are not doing the 4 cases or 5 cases a day. They're doing 1, maybe, or 2, because they rotate. So I don't want to say okay, we're not getting radiation, somebody else is getting it now, but they rotate. But the physician, remember, you're doing all the cases all day, right?
Dr. Mustafa, so Henry Ford, he said if I asked people what they wanted, they would have said faster horses. I think when we look at this, Model T built cars, that's why we're not driving carriages anymore. So when we look at this, we can't just look at it as a mechanism or a robot. There's software here that may dictate how we improve precision and safety 50, 40, 30, 20, 10, maybe 5 years from now. We drive cars now that have safety integrated that save you, your family, and your kids from accidents. There's tactile feedback built into steering wheels now, tires. The car can tell you if you're on the road or off the road. You can integrate all of these safety features. So this is not a hostile takeover of the operator. I think this helps you. It's your assistant, just like Jarvis is for Iron Man with Tony Stark. Sci-fi has led the way for many things. Blade Runner, Alien. Things that we laughed at 30 years ago are here. The iPhones, hoverboards, cars that are going to fly. So look at this maybe as a Model T, right? Go back 100 years and now think, well, if this is the beginning, and put it in the hands of people that can take it to the limits and then work with industry, kind of like Bill Cook, Charles Daughterway, and see what they come up with.
I like what you just said about work with industry. And I know a lot of people kind of frown upon physicians that work with industry. I just want to make it clear that I love working with industry. I don't want any financial reimbursement from that, but I want this kind of things from them.
Well, it takes guts to do this.
If we don't work with industry, if we don't tell them what we think, what we need, what we want, we will never get our catheter, we'll never get our wires, we'll never get our robotic arms. During this meeting, actually, I've asked many companies to build us many different things because during the presentations, there's so much unmet need. And I love your vision about this actually adds significant value. I don't want to relist them, everything that you listed, and I'll give Dr. Plagas a chance to say something. I'm sorry, George.
I've got no problem. I think it's a great display of where we are going perhaps in the future. And had I had this 30 years ago, I think I would have saved a few spots on my face. So from all the radiation injury. But let's take it to another level and predict. You're doing great. You're in the lab here. You're doing a great job with the robotics. Let's take it 3 to 5 years from now. Can you do telesurgery 200 miles away because they've got the robotic in the room? and they're going to say, you know, this is a little too complex for me. I'm going to call Dr. Mustafa. Let's see what he can do to navigate the wires, and therefore tell it, you know, you're going to be doing it, tell us, well, I'm not sure what the right word would be. You'll be able to do it robotically 300 miles away, and that way finesse that wire from Grand Rapids, and the patient will be in Wisconsin.
That's, you know, hold on a second. What you just said is, where's Fadi? Fadi, can you go to the mic, please? What you just said is exactly what Fadi is thinking. You know, Fadi is actually gone beyond the lab. 1 second, Larry, also. Fadi, so, you know, George's point and vision is similar to yours. What would you like to add to what he just said?
I would like to point out, though, this is being tested with the device on animal models. So there is, in the corner universe, there are physicians. One of our colleagues, cardiologist Dr. Mader, is actually doing that in Grand Rapids.
Okay.
So hopefully we'd like to see, maybe next year, Dr. Mustafa.
That is the point that I was hoping Fadi would make, is actually try to do something here next year. We'll see. And then an animal or cadaver where Fadi actually will be next to the radiation in Grand Rapids, and I'll do it from here. So hopefully we can pull that next year, pull it off, and that will be phenomenal. So actually we can ask different people from the audience to come up and try it, and we'll see. Next thing is, please, everyone, this is nothing for more than a selfish reason that we want to be able to do this quicker. So if anybody has any ideas, any feedback, please work with industry, and especially with this robotic concept, because we need it. It'll be nice for us to be able to do this faster, quicker, more efficient, and safer. I mean, all the stuff that was mentioned. I like that we were able to take a quick peek into the future. So hopefully next year we'll be able to look into the future further, and then look back into what would you call it, Michael? Paul, I'm sorry. What did you call your presentation? Back to the future.
Oh, Back to the Future.
Yeah. Well, thank you, everyone. I hope this was.
By the way, Dr. Mustafa, the Nike's shoes that were in Back to the Future, they came out 20 years later, and you can't even buy them again. They were so hot. So that's a nice way to end it.
Thank you so much. Thank you so much.